Hello, everyone. It's Dave Rosing. I'm just continuing our series here on documentation. So, as you guys all know, wound documentation is definitely critical for us to deliver proper wound care for our patients. And it helps facilitate the continuity of care between you guys, treatment nurses, you guys, and the family, and then you guys and the primary care physician. Also, it's key for us to get proper health data coding so that we're actually getting paid for and getting charged, etc., for the exact wound care that we're doing and for the exact right kind of wounds. Inaccurate documentation can be really bad for patient care and for overall wound healing. As an example, I'm sure you guys have taken over and somebody's wound measurements are completely off. Could have been mine. Apologies. Either way too big, way too small, etc. There may not be any detail of the wound care that the patient's been getting, just continued care, etc. So you really don't know if the wound is actually getting better, getting worse. You don't know if the treatments are working, etc. So the more that you're going to put into your documentation, the better. The way I like to think of it is, imagine like your biggest a-hole boss is going to be watching and taking over your patients for you, and you want to get all those things in order. If you can do it like that every time, you will actually end up being thankful for it. Unfortunately, almost half of the medical record notes that are done on wounds lack these key details on assessment and on intervention. So, just the basics, starting with wound etiology, the normal pressure ulcers, venous, arterial, diabetic, surgical, etc. Wound location. You got to use the proper anatomical terms. I'm sure you guys have seen. I see it all the time where a wound is clearly on the ischium, but for some reason it's documented as like the left buttock or even the sacral. And this can be a real issue, especially if state gets involved. They're like, "Are you covering up a wound? This is the wrong location." I myself have been guilty of putting the wound on like the wrong extremity. Like there's a wound on the left leg, and I'm like right lower extremity, venous ulcer, and completely realize it, weeks later, and have to go back and change the documentation. Unacceptable. But it does happen, obviously, so just pay attention to that. We can document on the thickness of the wound, partial thickness versus full thickness. Partial being into the epidermis or dermis, but not involving the subcu. Once it's involving the subcutaneous tissue, we now have a full thickness wound. So partial thickness would be such as skin tear, pressure ulcer stage 2, and full thickness is once you get into the subcu, like a stage 3 diabetic foot ulcer, etc. So wound size, length 12 to 6, width 3 to 9, and depth. Important to notice tunneling or undermining, ideally that first time you see the wound. Definitely made this mistake. Seeing a wound, I go back the next week, it's basically the same size, and then I kind of start feeling like there's like 3 centimeters of undermining here. Definitely a bad miss, and this is definitely going to affect wound healing. And it also gives you an idea of actually how much tissue damage there is. So if you underestimate it that first time, it makes it look like the wound has been declining, even though it really hasn't been. Wound bed characteristics, just like in our shorthand notes, you want to give your percentage of slough, granulation, um, eschar or epithelial tissue. Of note, epithelial tissue can be noted around the wound or islands of tissue within the wound. If the wound is 100% epithelialized, it is pretty much healed, unless you're talking about a stage 2 pressure injury. You want to note the wound odor, if it's mild, foul, pungent, or something fruity like a Pseudomonas infection. And then look for other indicators of infection. Is there pain, warmth, erythema, purulence, turbid drainage, etc. Looking at the wound edges and then the peri-wound area. Definitely key. Wound edges give you a good indication of how that wound's doing. If the wound edge is attached or unattached, I like to think of that as undermining. If the wound edge is pulled up, you're going to get some undermining or tunneling there, which can increase the time that it's going to take for that to heal. And then epiboly is basically when you've got the epithelial tissue growing over the wound edge, going all the way down to the granulation tissue. And this is going to really stall wound healing. And typically, you're going to need to take care of those edges there. If it's insensate, do whatever, but you may have to numb it up or use your spray, kind of get those edges cleaned up so that the wound can now go back to proper wound healing. Calloused or fibrotic edges, which we typically see in those diabetic foot ulcers or neuropathic ulcers. And then when you're looking at the peri wound, You want to look for stuff up to 4 centimeters outside of the wound. So edema, maceration, erythema, induration, etc. You want to document all that kind of good stuff. And then we're looking at wound exudate, serous, sanguinous, serosanguinous, purulent, turbid, etc. Those are self-explanatory. We're looking at actually exudate amount. This is pretty important because it does affect how we are able to bill and what kind of dressings will actually be covered for patients. For example, collagen and alginate need to have at least a moderate exudate amount. Great way to determine that is just to look at how much exudate is on the dressing. 25% would be in the minimum, 25 to 75% moderate. Above that, you're talking about large or copious amounts. And this will also determine what kind of treatment you're going to give. If you're having copious large amounts and your current management isn't working, you may want to add something like cellulose or a super absorbent dressing, etc. Sometimes they change the dressings right before you guys come. In that case, that's worthless, and you're going to have to kind of maybe listen to the patient or caregiver or treatment nurse. But either way, document. Going over staging, I know everybody knows the stages, but just to sort of reiterate, because this is actually a problem that can really get us in trouble documenting the wrong stage. As you all know, you cannot downstage. Once you stage something at a 3, it can no longer be a 2 or 1. Or if you document it as a 4, you can't downstage to a 2 or a 1 or a 3. You can say the wound's presenting now as a stage 2, but it will remain a stage 4. So stage 1, you've just got blanchable erythema. Stage 2, partial thickness, typically 100% epithelial. There have been studies, I've read one that came out in 2019 saying that they have been able to histologically find granulation tissue in stage 2s, but right now, according to the National Pressure Injury Advisement Panel, stage 2 does not have granulation or slough, so epithelial only. Stage 3 is when you do have an open wound with granulation, slough, eschar, only involving the subcutaneous tissue. And once it's down into the muscle, fascia, bone, or tendon, then that's a stage 4. Unstageable, another kind of key little documentation here. Definitely need to differentiate between unstageable and deep tissue injury. Unstageable, the wound is open, it's covered with an eschar, covered with slough. DTI is either intact skin or just basically that top layer may be ripped off, but it's just bruising, purple, black tissue. Unstageable, if you do debride it, you do need to stage that wound after you debride it, according to our billers. So be careful the way you do this. If you do an inadequate debridement or you just take out part of it and you're thinking it looks like a 3, and then the next time you come back and the debridement's a little bit more complete, the Santos worked, and then now you're down to muscle. Well, now it's gotten worse on your watch. So be very careful how you're going to document these. And photographs definitely help in these cases. And this is where I like to do a pre and a post. I know we don't always do the pre and post, but this is a good example of when to do that. Document the interventions that we're doing, what kind of debridement is being used, autolytic, especially if the patient's wound is just debriding and taking care of itself. Typically, if you're using hydrogel or hydrocolloids underneath those dressings, the wound will sort of clean itself. This is good for those patients that are on hospice or those who can't tolerate sharp debridement due to pain, etc. Enzymatic debridement, something like Santyl. Mechanical, just using gauze to wipe away the slough. Sharp, that's typically what we're doing. The curette, scissors, or scalpel, and then biologic, which I actually haven't seen done, but I'm kind of keen to take a whack at that. You can actually order medical maggots, and then they have dressings that basically kind of go over the wound and act as a silo for them. It'd be interesting if somebody had given that a try. For any patients that have undermining or tunneling that you're using a wound vac on, you definitely need to document how many pieces of foam were used. If it's just one for the wound, great, just document that as one. Sometimes you're taking small pieces and putting it into the undermined area or the tunnel. Definitely need to document this. Sometimes the nurses will take out the main piece and leave that one in the undermined area, and I've definitely had to go back surgically and remove these. They do not show up on x-rays, and this presents as a chronic, non-healing infected wound. Lawsuit. So we don't want that. Patient variable documentation. You want to report on the patient's pain. Pain is going to give us a good indicator if something's worse. Increased pressure, infection, etc. And then when you're documenting on patients' non-compliance, be specific about it. A lot of our patients are actually very nice and they're like, they're not offloading. They're like, yeah, I'm trying to keep my feet up, doc. Yeah, yeah. But the thing is that no matter how nice they are, you really still need to document it because it does affect our patient's wound healing. And it explains why it's taking longer for those wounds to heal. So always document that. They're not stopping smoking, not offloading, their diabetes is out of control, they're not following up with their endocrinologist, etc. You'll want to document all of the interventions we're doing. If you're giving them extra protein supplements, vitamins, you want to document any kind of repositioning that you're doing, heel protectors, offloading the heels, floating the heels, low air loss mattress, etc. And then any kind of laboratory work that you order, x-rays, ultrasounds, etc. I'm guilty of this. I've ordered labs. I've gotten the labs, and I'm like, great, those look great. And I fail to put them in the chart and I don't document it. Or I've gotten an arterial Doppler and I'm like, fantastic, bad disease. I knew it. And then I fail to document it. So always make sure if you're going to order something that you document it in the chart so it stays there. And then any kind of conditions that may negatively impact the patient, such as malnutrition, immobility, all that kind of stuff. Seems basic, but at the same time, remember to try to document it. We definitely do our initial assessment on these patients, and then, as you know, we do weekly notes. You can get weekly skin reports from treatment nurses or family members or caregivers if they're at the home. And these are things that are kind of important to note. If there are skin tears in this area or redness in that area, that might end up being a wound. If it is a wound, obviously document it. But even if it's not a wound, I would document it in case that turns into a wound later, so it didn't just come out of nowhere. You want to be very specific about your current treatment plan. We all put that down at the bottom of our note. And this is one of the more important things: caregiver or family education. If a wound is not going the right way, the number one way for you to protect yourself is to have a good relationship with that family and let them know everything that's going on. The wound's not getting better. I've cleaned it this way. I'm starting some antibiotics. We're going to do A, B, and C to try to get it better. Next week, I'll give you an update. I can text you or I can call you, which one they prefer, do it. It does take a little extra time, but it definitely is worth it. People are not going to typically sue their friends or someone they know who cares for their family member. It's someone who's never talked to them. The wound's gotten tremendously worse and nobody let them know. That's going to be an issue for you. Document also reasons for not changing treatment. The wound may be the same size, but it's increased in epithelial tissue, so the wound actually is getting better, or the wound's about the same size or a little bigger, but the depth is less, something like that that can explain why you're not changing your treatment. And then, of course, any referrals that you're placing, document. And then also document what the referral doctor says whenever they come back. If it is somebody who you're waiting for a vascular consult on, I put it in every note so that it's always on my mind and my reader's mind that this was going on in my head, waiting for vascular to see my patient. So, in summary, guys, document everything you can. If you don't document it, it did not happen. This is the one thing that you can protect you from any kind of lawsuits and whatnot. Doesn't mean you won't have them, but this is your best chance at looking back and proving to everybody else that you did the right thing. Like I said, if you're imagining like that crazy boss that's going to look over you and just pick over everything, if you can do your notes every time that way, you'll be better off for it. All right, guys, have a good day. Enjoy rounding. If this is a night, have a good night. Take care. Bye.